comprehensive, relevant, and insightful conversations about health and medicine happen here on MedStar Health DocTalk. According to the American Cancer Society, about 66,000 new cases of uterine cancer will be diagnosed this year. It is the most common type of gynecologic cancer and most frequently occurs in women over the age of 45, though it can affect younger women and the numbers are rising. We've invited gynecologic oncologist Dr. Ali Mahdavi from MedStar Health in Baltimore to talk about symptoms, diagnosis, and treatment of uterine cancer today on MedStar Health DocTalk. I'm your host, Debra.schindler. Thank you for being here, Dr. Mahdavi.
Thank you, Debra.
The uterus is located behind the urinary bladder and in front of the rectum in a woman's abdomen. It's a singular organ, but there are two types of cancers that can develop in the uterus. Let's talk about them.
The most common type of uterine cancer is endometrial cancer. Endometrial cancer originates from the inner lining of the uterine cavity. The origin of the cancer is the glandular tissue that covers the endometrial cavity, and the most common symptom for endometrial cancer is abnormal vaginal bleeding. Sarcoma is less common compared to endometrial cancer, and it originates from the smooth muscle of the uterus. This could be the smooth muscle that is found in the wall of the uterus, or the smooth muscle that originates from the endometrial lining. Overall, the symptoms for uterine sarcoma is similar to endometrial cancer, with the difference that sarcoma could present as a mass originating from the wall of the uterus that could be mistaken with a more common uterine condition called fibroids.
So I was very surprised to find out that even at my age, that all the years that I've been getting a Pap test, it was not to detect uterine cancer. And I asked some friends and other women who are at an age that they would have been receiving a Pap test for many, many years, like myself, and they were equally shocked to find out that Pap test does not detect uterine cancer, that is only for cervical cancer.
Debra, you're correct. Pap smear is intended to be screening for cervical cancer. We do not do Pap smear to detect endometrial cancer. Having said that, there are situations that we see endometrial cancer cells on the Pap smear, and that is highly suggestive of diagnosis of endometrial cancer. In these cases, we proceed with endometrial biopsy to confirm the diagnosis. But in general, there's no good screening method for general population for endometrial cancer. But fortunately, most of the endometrial cancers are diagnosed in early stage because in the early stages, they are associated with symptoms such as bleeding that brings the patients to gynecologists, and further workup in the direction of the diagnosis is made.
So what you described as a symptom being excessive bleeding could be a lot of things, right? Fibroids or just bad periods. How is a woman to know if she has uterine cancer?
Unfortunately, we do not have a good screening method for the general population for endometrial cancer. But fortunately, endometrial cancer is associated with symptoms in very early stages of the disease. For example, in postmenopausal women, any bleeding or even spotting is abnormal. And this has to be addressed by a gynecologist, either in a form of ultrasound or endometrial biopsy. So in summary, although we don't have a good screening method for endometrial cancer, the fact that endometrial cancer presents in early stages with symptoms that could direct us towards the diagnosis results in making the diagnosis in early stages.
Would the difficulty in diagnosing or the lack of symptoms with uterine cancer be reason enough for the numbers to be on the rise? I mean, we've made such great strides in oncology, in detection and treatment. Why are the numbers on the rise?
You're right. The numbers are on the rise, not only in the United States, but in most developed countries. As I said, fortunately, the endometrial cancer is associated with symptoms in early stages. So the rise in the numbers is not due to lack of symptoms. It's mostly due to increased prevalence of obesity in developed countries. And as we will discuss later, obesity is one of the most common risk factors for endometrial cancer. In addition, the death numbers from endometrial cancer are on the rise. And endometrial cancer are among few cancers in the United States that we have not been able to decrease death numbers based on the general population. Despite all of the efforts and advances that we have in treatment of endometrial cancer, we have not been able to decrease the death numbers.
That's very alarming. A woman comes in, she's presented to you, perhaps she's premenopausal and she's finding herself bleeding more heavily or more frequently. What do you do then to diagnose her or to check her for uterine cancer? What's the next step?
As I mentioned, in women in menopause, any bleeding, even mild bleeding or spotting, is abnormal. And even in women who are not in menopause, significant irregular bleeding, especially bleeding between periods, is considered abnormal. And the workup and the tests that are usually considered in these circumstances are ultrasound, pelvic ultrasound, and biopsy of the inner lining of the uterus or endometrial biopsy. Diagnosis of endometrial cancer and uterine cancers in general is made by biopsy. Ultrasound can help us in finding women who would be at higher risk for endometrial cancer, but ultrasound is not diagnostic by itself.
All right. Explain the biopsy then. How does that happen? How does that take place?
Endometrial biopsy is usually done in the office setting. It is a common procedure that gynecologists and gynecologic oncologists perform in the office. It starts with vaginal exam, like when we do a pap smear, exposing the cervix, and then passing a small tube or catheter inside the cavity of the uterus through the cervical opening. With applying suction on the biopsy device, we obtain tissue from the endometrial lining, and usually the procedure takes not longer than a couple of minutes, and the patients can experience some cramps and mild pain after the biopsy, but generally it's very well tolerated in most cases. In patients that we know in advance that will do endometrial biopsy, we'll ask them to take some over-the-counter medications such as Tylenol or ibuprofen prior to the procedure.
You described that the pain would come after. What about during the procedure?
During the procedure, it is associated with cramps, some cramps, but usually the cramp and the pain is not significant. It's tolerable, especially if patients take medications prior to the procedure.
And how long does it take to get a result back?
Typically, it takes between 3 to 7 days for the result to come back.
And you can't see that when you're looking up there through a scope. Are you able to see anything?
We can't see the endometrial cavity with the endometrial biopsy.
Okay.
But we can see the tissue that is obtained during endometrial biopsy. There is another procedure called hysteroscopy or office-based hysteroscopy that could be done in the office. That procedure requires distending the endometrial cavity, and with direct visualization of the inner lining of the uterus, we could do the biopsy.
And would you be able to see if there was cancer?
We could see some changes that would be suggestive of cancer, but just seeing the inner lining of the uterus is not diagnostic for cancer.
Like, I understand you wouldn't want to say to the patient, this doesn't look good or this looks suspicious. In your mind, are you thinking this looks like cancer? Does that ever happen?
There are some features that are highly suggestive of cancer, but we usually do not make the diagnosis until we have the pathology result back.
Oh, which is better? Which is a better approach to getting that biopsy sample?
We start off with endometrial biopsy, and if there are circumstances that the endometrial biopsy is not conclusive or is not feasible, then we proceed with hysteroscopy.
Why wouldn't you just do that one first? It sounds like it's more accurate or more thorough.
It is In some cases, we do a hysteroscopy on a routine basis, but we usually start with less complex procedures, and if we can get the answer that way, would be even more comfortable for the patients.
I see. Can you use a transvaginal ultrasound to detect endometrial cancer?
Transvaginal ultrasound cannot make the diagnosis of endometrial cancer. However, there are features that are highly suggestive of endometrial cancer. For example, if a menopausal woman has bleeding and the ultrasound shows that the inner lining of the uterus or the endometrial lining is significantly thickened, the symptoms and the findings on the ultrasound are highly suggestive of cancer.
Why do you think we hear so many more cases of younger women dying from uterine cancer?
I would like to discuss the risk factors for endometrial cancer, and that would explain why we see more patients diagnosed with endometrial cancer and why we see endometrial cancer in the younger population.
Okay, sure, fair.
One of the most common risk factors for endometrial cancer is obesity. As you know, in the United States and developed countries, we are dealing with significant rise in the number of women who are considered obese. I think the most important factor in increase in number of endometrial cancers and making the diagnosis in the younger population is the rise in the number of patients who are obese in the country. In addition, diabetes and family history of uterine cancer and a certain type of hormone, especially if a woman is exposed to unopposed estrogen, would increase the risk of endometrial cancer. There are some drugs such as cancer drugs. One example would be tamoxifen. That also increases the risk of endometrial cancer. Certain types of endometrial cancers that run in families, and there is a genetic basis for these cancers. And these genes are passed from one generation to the next. For example, Lynch syndrome is a genetic condition that puts a woman at risk for endometrial cancer and colon cancer. About 5% of endometrial cancers that are diagnosed in the United States could be related to these hereditary and genetic syndromes.
So without screening, it is critically important for women to pay attention to their symptoms. And what are they then when they do have symptoms?
Most common symptom for endometrial cancer is abnormal vaginal bleeding. In any woman in menopause age, any kind of bleeding, even a very mild bleeding such as spotting, would be abnormal, and this needs to be brought to the attention of the primary care or the gynecologist. In these cases, we usually proceed with endometrial biopsy to rule out any precancer or cancer condition of the uterus. In more advanced stages, there could be other symptoms such as pelvic pain and abdominal distension, a sense of fullness in the abdomen, nausea, and other symptoms that we see with endometrial or ovarian cancer. But in general, the first symptom and the earliest symptom for endometrial cancer is abnormal bleeding, either in a form of bleeding after age menopause or in women who are not in menopause stage, but they have significant irregular bleeding, especially abnormal bleeding between their menstrual cycles.
But I think that's very common with young women, or a lot of women premenopausal, to have breakthrough bleeding or unusual or irregular periods. So that wouldn't necessarily trigger any kind of concern. So when should she be concerned enough to say, I need to be screened? And does she have a say in that? Would her insurance cover it if she's at a certain young age?
Sure. In women who are close to age of menopause, typically after age 40 or 45, if there is persistent abnormal bleeding, especially heavy bleeding, irregular bleeding, and bleeding between periods, it requires further workup, either in the form of ultrasound, endometrial biopsy.
So your recommendation would be to ask your doctor to get a biopsy or an ultrasound?
My recommendation would be to discuss the symptoms with your physician. There are certain women who are at higher risk for endometrial cancer, for example, women who are overweight or obese, or women who have strong family history of endometrial cancer. and women who are closer to the age of menopause. So any abnormal bleeding in this population would be concerning. In younger women who are otherwise healthy, in most cases, irregular bleeding does not trigger an extensive workup because the risk of endometrial cancer in a healthy, normal weight young woman is relatively low.
But not unheard of. I mean, actually, it's these young girls who look like, they're on the cover of a 17 magazine that we hear about dying that makes the news, that gets circulated all over social media. It's when these young girls have these undiagnosed cases.
That is correct. It's not unheard of, but usually in very young women, I'm talking about women younger than age 30, there are other risk factors that put the patient or the woman at higher risk for endometrial cancer, as I mentioned, with obesity or strong family history of endometrial cancer.
So given that, what are some of those other risks? Now, you mentioned obesity. What other risk factors might play into a diagnosis?
The most common risk factor would be advanced age. Women who are older than 50, they're at significantly higher risk of endometrial cancer. The average age of diagnosis for endometrial cancer is between 60 to 65. Obesity is another risk factor. History of diabetes, family history of endometrial cancer, and long-lasting history of abnormal uterine bleeding. Some women are treated with unopposed estrogen for a variety of reasons, and those women would be at higher risk for endometrial cancer as well. Certain drugs, such as tamoxifen, which is a drug that's used in treatment of breast cancer, can also increase the risk of endometrial cancer.
So a woman who's on tamoxifen might opt to have her uterus, her hysterectomy? Is that why they sometimes make that decision, like prophylactically?
Not necessarily. But they have to be closely monitored. And if there is abnormal bleeding, they require an endometrial biopsy. In women who are at significant risk for endometrial cancer, we consider prophylactic or risk-reducing hysterectomy. But in general population, we do not recommend prophylactic hysterectomy.
Okay. I thought women who had breast cancer with the BRCA gene were also at risk for uterine cancer. Is that not true?
It is true for BRCA type 1. There are some studies that suggested that women who carry BRCA1 gene mutation, they're at higher risk for certain types of endometrial cancer. So in carriers of BRCA1 gene mutation, when we talk about risk-reducing or prophylactic removal of the tubes and ovaries, sometimes we discuss the option of hysterectomy to further decrease the risk of gynecologic cancers.
But I wanted to go through some of these other statistics that I found to be really very interesting. Uterine cancer is generally more common in older women, as you had mentioned, and has for a long time been disproportionate in survival rates of Black women compared to white women. For white women, the 5-year survival rate is 84%, but 64% for Black women.
I think there are two components to increase risk of death in African American women. First one, I believe it's access to care and disparities in healthcare in African American women. Some may not have access to primary care physician or gynecologists to have adequate workup and testing for diagnosis of endometrial cancer. The other factor is that we see high risk endometrial cancers, the cancer types that are more often associated with spread to other organs, such as high-grade serous endometrial cancer, in African American more often than white women. There could be some genetic basis for this finding, but in general, high-risk endometrial cancers are seen more often in certain population, and the treatment is more challenging, and the outcome is less favorable. Which
leads to the next data point. Now, new research indicates that uterine cancer also is on the rise among reproductive-aged Hispanic women. According to a study of 840,000 uterine cancer patients, Published in the journal Gynecologic Oncology, Hispanic women had the highest uterine cancer rate among young reproductive-aged women between the ages of 35 and 39. Cases have been rising steady, 4% each year since 2001, a rate that is 50% higher than that of white women. That's very alarming.
You're correct. And we have seen in our practice as well. I think there are two reasons for this increase in incidence of endometrial cancer in Hispanic population. One could be access to care and later diagnosis of endometrial cancer. And the second reason is that some of the risk factors that we talked about, such as obesity and diabetes, are more common in Hispanic population. And with lack of access to primary care, sometimes these conditions are not very well controlled and further predispose this population to endometrial cancer and other health conditions.
The journal report does cite obesity and diabetes as a cause for that, saying that both are found to be disproportionate as well in the Hispanic population. Uterine cancer is the most common cancer occurring in the female reproductive system. Are there causes for that? And is the sarcoma, uterine sarcoma versus endometrial cancer, is one worse than the other? Is one easier to cure?
The incidence of endometrial cancer, as you mentioned, is increasing in the United States. Despite all of the efforts and the research that have been done for prevention and treatment of endometrial cancer, not only we see increased risk of or increased incidence of endometrial cancer, we see a rise in the number of deaths from endometrial cancer in the United States. This could be due to the rise in obesity in the developed countries and other risk factors, exposure to environmental toxins and other factors, increased incidence of diabetes and change in lifestyle, and decreased physical activity among a younger population.
So once a diagnosis is made, what is the first step for treatment?
The first step in treatment is a comprehensive review of the medical and surgical and other related histories of the patient. In most cases, early stage endometrial cancer is treated with surgery in patients who are surgical candidates. The surgery includes hysterectomy, and in women who are close to menopause, removal of the tubes and ovaries. And in some cases, we sample the lymph nodes to make sure that the cancer is not spread. This is called endometrial cancer staging. Fortunately, we do most of these cases through minimally invasive approach, either robotic surgery or conventional laparoscopic approach. The benefit of minimally invasive surgery is faster recuperation, less pain, less scar formation, a lower complication rate, and arguably they are as effective, if not more effective, than traditional surgery with open incision.
Is chemotherapy a part of the treatment?
Chemotherapy is part of treatment in more advanced stages. Fortunately, most of the endometrial cancer presents in early stage, and for a large number of women, surgery is curative.
Is there any suggestion that women who have endometriosis are going to later develop endometrial cancer?
Yes, there are some studies that suggest history of endometriosis would put women at higher risk for endometrial cancer as well as ovarian cancer. In this patient population, especially those who have undergone surgery, we thoroughly examine the areas that are suspicious for endometriosis to make sure that there is no cancer component.
If someone has had cervical cancer or ovarian cancer, is that an increased risk?
Cervical cancer does not put a woman at higher risk for endometrial cancer by itself. Cervical cancer is usually associated with HPV infection, and HPV infection is not considered a risk factor for endometrial cancer.
Okay.
However, women who are diagnosed with ovarian cancer, most cases, the uterus is also removed at the time of ovarian cancer surgery, and we occasionally see women who have both endometrial and ovarian cancer. And there are some genetic conditions or hereditary cancer syndromes, such as Lynch syndrome, that not only increases the risk of endometrial cancer, but put the patient at risk for ovarian cancer as well.
So is there a preventive for people who have Lynch syndrome? Would there be a preventive approach?
Yes. So women who are diagnosed with Lynch syndrome, in general, they're at about 40% risk of developing endometrial cancer during their life. There are different types of Lynch syndrome, and the risk of endometrial cancer would be different in these different types. But in general, on average, the risk would be 40%. And Lynch syndrome is one of the rare conditions that we do screening and close follow-up of these women as they're at significant risk for endometrial cancer. In general, in women who are diagnosed with Lynch syndrome, if they're done with childbearing between age 35 to 40, we recommend risk-reducing surgery that would include hysterectomy and removal of the tubes and ovaries. If the decision is made not to proceed with risk-reducing surgery, or at around age 30, we recommend periodic ultrasound and endometrial biopsy to diagnose endometrial cancer at the early stage.
Is immunotherapy ever used to treat uterine cancer?
Yes, in the last 5 years, we have made significant advances in the treatment of endometrial cancer. Now, we have targeted therapies, including immune therapies, that are highly effective in certain types of endometrial cancer. When we make a diagnosis of endometrial cancer as a routine procedure, we do what we call it molecular profiling of the tumor. And that shows the gene alterations that are seen in the cancer cell and whether the cancer cell is sensitive to immune therapy or not. If the genetic profiling test or molecular profiling test is favorable, these patients would be responsive to immune therapy with remarkable response. There are cases that not too long ago were considered terminal cases, and these patients were referred to hospice. And today we can offer them immune therapy, and they have remarkable response to immune therapy. Again, I have to emphasize that the response to immune therapy is not the same in all types of endometrial cancer.
Have you had cases like that really surprised you?
Yes, actually, not too long ago, I had a patient who came to me for second opinion. She had surgery at a different facility, and she developed recurrence of cancer in the abdominal wall. And after we did the biopsy, what was the previous surgery? It wasn't to remove the uterus. Yes, it was actually. It was a hysterectomy, and this was done 8 months before the patient presented to me. And when the patient presented to me, she had a large mass on the abdominal wall, and the mass has eroded into the skin, and she had a open wound that was not healing. She was treated with chemotherapy, and she had minimal response to chemotherapy. And when we tested the tumor, we found that it was sensitive to immune therapy. And I was pleasantly surprised that with a few cycles of immune therapy, the wound completely healed, and the patient had no evidence of any remaining disease. And I'm in touch with my colleagues who are following this patient, and to this date, she does not have any evidence of recurrent disease. That's amazing.
So her tumor was in the uterine cancer?
We usually biopsy the lesion when there is a recurrence. We biopsy the lesion, and we could test the tumor. In addition, when a surgery is done, a tumor is preserved by the pathology team, and later on we could test a primary tumor for molecular profiling.
So you're not sure then yet?
No, in this particular case, I biopsied the area that was recurrent in the abdominal wall, and we tested the recurrent tumor.
I mean, you're calling it a recurrent tumor. Does that suggest that it was from the uterine cancer? It was left over?
That is correct.
Okay.
This was confirmed to be recurrence of the endometrial cancer.
Oh, wow. Even without the uterus, it was still growing in her body. That's amazing.
That is correct.
Wonderful that you were able to help her.
Yes.
I keep seeing broadcast ads from law offices soliciting anyone who uses a hair relaxer and has received a uterine cancer diagnosis, to call a certain number, call our law office. Is there a connection, truly, between uterine cancer and the use of hair relaxers?
So these reports are based on a study that was recently published looking at more than 30,000 women and following them for 11 years. And what they found was that women who were exposed to hair relaxing products were at almost twice the risk for endometrial cancer. It's believed that reason for this increase in risk is that these products, they act and behave like estrogen. And as we discussed before, unopposed estrogen could increase the risk of endometrial cancer. These products not only increase the risk of endometrial cancer, but also increase the risk of ovarian and breast cancer in that study. We have to be careful that this report is based on one study. Impact of this effect in general population is yet to be determined. But certainly in this study, African American women were more affected by these products.
Should women be concerned about other hair products, such as a hair color, for example?
Well, it's premature to say that other hair products could be carcinogen. But using these products, hair relaxing products, should be limited, and I think alternatives should be considered.
Okay, so in summary, what do you advise listeners do to prevent uterine cancer?
In general, healthy lifestyle, maintaining a healthy weight, and balanced diet are very important. In addition, reporting early symptoms of endometrial cancer, such as abnormal vaginal bleeding, especially in women who are in menopause, should be very important in early detection of endometrial cancer.
Is there anything else that you think people should know about uterine cancer?
This is an exciting time for research for endometrial cancer. We have made significant progress in management of endometrial cancer, especially advanced stages. I hope that in the near future we see the reversal of the trend in increase in mortality and incidence of endometrial cancer. But I can't emphasize enough on a healthy lifestyle, maintaining a healthy weight and a healthy diet.
I hope that you're right, that there are some changes, some positive. And as a mother of 3 daughters, I really hope that you were right. Thank you, Dr. Mahdavi.
Thank you so much for the opportunity.
We've been talking with Dr. Ali Mahdavi at MedStar Franklin Square Medical Center in Baltimore. Thank you so much for sharing your expertise with us here today on MedStar Health DocTalk. For more information on uterine cancer or to schedule an appointment, call 443-777-7990.